Said I'd like to thank the organizers and JV Pharma for this session. This is a sponsored talk and the slide deck has been prepared by the company and I'll just be sharing it with you. So the idea of this talk is to kind of give you an insight into the role of Nepafenac 0.3% in the management of macular edema in diabetic patients undergoing cataract surgery. So why diabetic patients specifically? I'll make the case for that. Basically, cystoid macular edema is much more common in diabetic population compared to normal population, and this drug is specifically approved for that. So Ilevro from Novartis, which is now in India marketed by JB Pharma. So to give you an overview, there are 100 million people worldwide showing some signs of macular edema secondary to diabetes, and 1 in 3 people with diabetes have some evidence of macular edema. So that's a very, very common problem considering diabetes is an epidemic in India right now. 77 million diabetics in India have diabetic macular edema. 2% of them have diabetic macular edema. Around 22% of diabetics who undergo cataract surgery can develop macular edema. So that's almost 1/4 of all cataract patients who are diabetic will have macular edema. And I'm sure all of you who are doing cataract surgery, at least half or 2/3 of your list patients are nowadays diabetic. I'm sure you agree with me. So cataract surgery increases the risk of post-surgical edema or worsening of pre-existing edema exacerbated by pre-existing diabetic retinopathy. So if you have existing diabetic retinopathy, the risk becomes many-fold more. 68% of these patients will resolve spontaneously within 6 months, peaking at 6 weeks. Pre-existing macular edema, if it's present in patients with diabetes, will tend to have a worsening after cataract surgery and a more severe course after cataract surgery. This was a large study in UK, 81,984 eyes, which showed increased new onset diabetic macular edema post-surgery. So there was a 1.8 times higher risk of macular edema in patients who were diabetic without retinopathy, and a 6.23 times higher risk in patients who were diabetic with pre-existing diabetic retinopathy. So if you have pre-existing diabetic retinopathy and you're going for cataract surgery, there's a huge chance that you're going to end up with macular edema. So this subset, I think definitely one must use some sort of a prophylactic measure. And in general, I think all diabetics, there is a significant case for using prophylactic medication to prevent cystoid macular edema after surgery. What are the effects on vision? Significantly impairs the visual rehab after cataract surgery and affects retinal morphology and visual function. Excess intraretinal fluid can cause irreversible structural damage and permanent vision loss. So topical NSAIDs are an effective strategy to prevent post-surgical macular edema in diabetic patients, just like they are for all other patients as well, and we all know that. These are the mainstay of prophylaxis for cystoid macular edema. So what are the options we can use other than NSAID for preventing and managing cystoid macular edema after cataract surgery? Topical steroids can be used. They have lower penetration into the eye compared to NSAIDs, give superior results when combined with NSAIDs, but there is always a risk of raised intraocular pressure with the use of topical steroids. Lasers have been used for diabetic macular edema, enlargement of laser scar, transient increase of diabetic macular edema, accident foveal burns, or choroidal neovascularization can happen because of damage to the Bruch's membrane, and that can permanently affect the vision, and even there can be loss of some lines of visual acuity. Triamcinolone acetonide has higher risk of increasing IOP, we know that, if you give an intravitreal injection. And other intravitreal steroid options are also available, which can cause risk of increased intraocular pressure. Not all patients demonstrate a response to anti-VEGF treatment, so it doesn't work in all cases, the intravitreal anti-VEGFs. And if they do work also, you may have to give a lot of injections sometimes. So what is the mechanism of topical NSAIDs? They block the cyclooxygenase pathway, reducing the prostaglandin production and vascular permeability, thus decreasing macular edema. Common NSAIDs that we use are Nepafenac, diclofenac, bromfenac, and ketorolac. So preoperative use of NSAIDs is recommended in eyes without preoperative diabetic macular edema also to reduce the risk of developing diabetic macular edema postoperatively. So what is the case for Nepafenac as a prophylactic treatment for macular edema in diabetic patients undergoing cataract surgery? I think this couple of randomized prospective multicenter double mask studies are a significant case. So the study 1 and study 2, you can see both there is a significantly lower incidence of macular edema within 90 days after cataract surgery in the study population which received Nepafenac compared to the control population which received the vehicle. And the pooled analysis showed 4.1 in the study population versus 15.9% incidence in the patients who didn't receive any NSAID. So this is a statistically significant difference between the two groups, showing that clearly the benefit of topical Nepafenac in preventing postoperative edema in these patients. And there were no unanticipated adverse events observed in these cases. How is Nepafenac better than the other NSAIDs that are available in the market? It has been proven to be effective against pseudophakic CME development, increased target activation, greater duration of action, and I think this is the last one is the most important. It has very good permeability and penetration into the eye and reaches the retina better. So what are the key takeaways? Diabetic macular edema is accumulation of excess fluid in the extracellular space within the retina in the macular area. Approximately 22% of diabetic patients develop macular edema following cataract surgery. Nepafenac is proven to be effective in reducing the risk of postoperative macular edema in diabetic patients. Compared to other NSAIDs, Nepafenac has higher permeability, greater duration of action, and increased target activation. Thank you.
Thank you, sir. A crisp and concise presentation. I have one question, sir. Practically, do you start NSAIDs in all your diabetics post-op, or is it dependent on the baseline sugars?
So earlier I was using them only for diabetics and patients who had like a traumatic surgery or where I was anticipating CME. But now I've made it a protocol for all my cases. I started a few days before surgery and continued till 6 weeks after surgery.
Thank you so much. Do we have any questions in the house? Right, thank you. Thank you so much. Yes, sir, please.
Do you feel by using diclofenac as tablet, if you use diclofenac tablet before surgery, along with the Nepafenac, does it make any difference in results? Because it is written in the literature that diclofenac tablet, if you use before the surgery, then it reduces the chances of macular edema in general.
I think prophylactic oral NSAID, why do you want to unnecessarily give it? They have their own side effects. They have renal toxicity and gastritis. So maybe for the pain, if you're giving it, it's fine. But I don't think prophylaxis of CME, it makes it.
Anybody else is aware
I'm not aware of.
Yes, it is mentioned. I read in the John L. Parr, textbook of intraocular lenses by John L. Parr. He mentions that the studies are there that if you use diclofenac tablet, a day before, 100 milligram tablet, a day before the surgery, if patient needs antacid, you can give antacid. Rather, with all the NSAIDs given orally, one has to give antacids. Otherwise, they may cause micro ulcers in the intestines. That is not a problem, but it does reduce chances of the macular edema in general.
Anybody who is following this practice, no? Rajesh, sir, would you comment on this?
Doing systemic NSAID. Yes, earlier we used to give, even for, when somebody developed macular edema, then we used to give Indocap SR and all those things long back, many years back. But these days, in our practice, we are not giving systemic NSAID. We are not giving that. In high-risk cases, not in all cases, we give NSAID topical as well. But yes, in high-risk cases, post-uveitic or any complicated scenarios, we like to give topical NSAID in these patients.
Right.
0.3 is one time a day, Nepafenac. If you're using concentration of 0.1%, it's 3 times a day. And if you're using 0.3%, it's once a day. Yeah, that dose will not change.